So for my patient outcome rehabilitation plan, I am going to be talking about acetabular dysplasia and returning to play after periacetabular osteotomy. So my PICO question is, would physical therapy or periacetabular osteotomy have more long-term benefits for an adolescent female soccer player with acetabular dysplasia? So some basic patient information. She is a 14-year-old female soccer player. She plays high school and travel ball. She is complaining of right hip pain. She's been achy for about 2 weeks and feels a catching sensation in her hip during running and practice drills, and she has no previous history of hip injuries. To confirm my diagnosis, we referred to a physician for imaging, and she had x-rays were positive for acetabular dysplasia in her right hip, and the MRA showed a labral tear in her right hip. So my timeline for this rehab plan is the initial evaluation was taken at the time of reported symptoms. The physician confirmed the diagnosis. We decided with the physician and the athlete and her parents to do prehab for 4 weeks just to get her as strong as possible and ready for surgery. The surgery was periacetabular osteotomy with labral debridement. The rehab protocol began 3 days after surgery with me, and then she was discharged after 21 weeks of rehab. So my initial evaluation with her, she was tender to palpate at the right greater trochanter, the piriformis muscle, and the proximal adductor attachments. She had decreased active and passive range of motion, especially at end range, and flexion, internal rotation, and adduction. All her manual muscle tests were within normal limits. She had a lot of positive special tests. She was positive Fader, positive Faber, positive straight leg raise, positive anterior impingement test, positive hip scouring test, and a positive Trendelenburg sign. And then we ruled out SI dysfunction and tight hamstrings and quads. She was negative Thomas test, negative SI compression, negative SI distraction, and all her neurovascular was within normal limits. So from this, I suspected an acetabular labral tear or either femoral acetabular impingement. And the patient seems pretty discouraged by this, but we referred her to a physician to confirm with imaging. I pulled her from practice and we did ice and NSAIDs for pain. We created some short-term goals, and they were to relieve the pain, increase her range of motion, increase her strength, increase her cardiovascular fitness to make sure she was ready to return and get ready for surgery. Some long-term goals are return to play, of course, pain-free range of motion, and pre-injury athletic level of fitness and confidence. And then for treatment, like I said, we had to get the imaging results to confirm the diagnosis, and then we decided to do 4 weeks of prehab surgery, and then we estimated 20 weeks of rehab, but we let her know that this may vary depending on how it goes. So we did document every day that she did treatment. She did treatment 3 times a week throughout her whole time with me. And for my first follow-up evaluation that I'm sharing, it was 3 weeks of prehab. And so she reported her pain level today was 4 out of 10. Her tissue test still provoked some mild pain, but her active and passive range of motion is improving, just with some mild pain at end range. We focused on some strengthening exercises to target those hip flexors, abductors, adductors, and rotators, like doing clams and side steps. Just some things with resistant bands to work on flexibility. We're avoiding pain when we're working on range of motion, and we're also working on some balance and trying to improve her best testing scores. And then also doing cardiovascular testing, like on the bicycle or in the water. And then before exercises, we did moist heat with e-stim to relax the tissues. We did inferential at 8150 for 15 minutes. And then after exercises, we would do game ready for the ice and compression to alleviate some of that soreness. To do an outcome measure before her surgery, we wanted to do the modified hip Harris score, and she scored a 65 on that. And then we also did best testing, so we would have something to compare afterwards. And she had 15 errors on the best test. And so she has surgery in 1 week, and so we're just trying to maintain some normal level of function to prevent physical functional decline and achieve quicker recovery of post-surgical function. And then for the next follow-up evaluation, she was 4 weeks post-op. So she was ambulating with 2 crutches at this time. Her pain level was a 2 out of 10, and she was still increasing active and passive range of motion and increasing her strength. And she showed this by doing some goniometer measurements. And then we also did ultrasound before this treatment just to try to relax the tissues. And then we did aquatic therapy today. We did some walking, kicking, standing, hamstring curls, ankle pumps. Only doing waist deep just to not have it too intense since she's only 4 weeks post-op. And then after that, we did some more measurements. So she scored a 68 on the modified hip Harris score. Goniometer measurements, as I said, and those were showing improvements. And we're going to continue to do treatments 3 times a week. And she's really enjoying the aquatic therapy. I think that's really helping, especially her confidence. Like she feels like she can do more in the water. So we're still in the proliferation phase, and we'll probably be in the proliferation phase for about 2 more weeks. And then in the next 2 weeks, hopefully she'll be pain-free. And then our goal is to increase the hip flexion to 100 degrees, and so she can advance to the next phase. And the patient will begin to ambulate with 1 crutch within the next 3 weeks, and we will also progress the strength exercises. My next follow-up evaluation was 13 weeks post-op. She began ambulating without crutches 3 days ago. She feels great, no pain. She's continually improving on her active and passive range of motion and increasing her strength, and this can be shown by the goniometer and thigh girth measurements that were taken. We did another modified hip Harris score. She scored an 88, which is great. It's almost there. And then we did a 6-minute walk test, and she was able to do 438 meters in 6 minutes, which is pretty good. We will continue treatments 3 times a week, and we are going to begin the functional exercise phase today. Since we did a lot of testing today, it won't be as much in the treatment room, but we're going to start on the bike for 5 minutes and then gradually increase the intensity throughout, and she will be able to do 15 minutes pain-free within 2 weeks. She will have full range of motion in 3 weeks, and then we're going to continually increase resistance on the strengthening exercises and start really focusing on the core strength. The goal is to begin sport-specific exercises in 4 weeks. And then so my final evaluation, she was at 20 weeks post-op. She feels like $100, better than before, no pain, which is great. We did a lot of outcome measures today. The quality of life survey was done just to make sure that she was stable, or her mental status, and then also seeing just how she feels physically, like what her perception of it is. We did another 6-minute walk test, and she improved greatly. She's at 542 meters in 6 minutes. We did the Y balance test, and she's at 94% testing bilaterally, so that's really great. She only scored 3 errors on the best test, so it's a vast improvement from when she was pre-surgery. We did a functional hip sport test score, so that really shows if she's ready for sport or not, and she got an 18, which is passing. And then we did isokinetic testing, and she showed 93% comparing bilaterally of strength, so that's awesome. And so the goals that we met are full range of motion, pain-free, comparable strength, gait is normal, perform sports drills at pre-injury accuracy and speed. Her confidence level is great, and then she's cardiovascularly ready to perform as well. So I feel like she's ready to return to practice with the team. She will continue agility and sports-specific drills with the team, And then next week she's going to go full practice. So I'm ready for her to do well. And of course, if she needs any maintenance, she can still come to me, of course. So some evidence from the literature to support what we have done. So the standard corrective procedure for acetabular dysplasia is a periacetabular osteotomy, because just correcting a labral tear, it's going to fail if you have dysplasia just because of the structural deformity. So patients that underwent a labral repair and a PAO had greater changes in patient-reported outcomes when compared to only having a PAO. So fixing the labral tear and the dysplasia gives you the best benefit, and that's what we did. About 20% of the recreational athletes returned to play within 6 months of the surgery, and the only factor hindering them was pain. Out of all the patients who returned to play, 73% reported their athletic performance at the same or higher level after surgery. So I feel really good about deciding to do this, and hopefully she'll get back out there. I found many systemic reviews. I found one systemic review of many return to play protocols. And then the most common outcome measure was a modified hip hair score. That's why I used it. And it's typically used pre-surgery, 1 month, 3, 6, 9, 12, however many, but mostly 6 and 12, I believe. So that's why I wanted to use that. It provides mostly subjective data, but there's also some objective data in there as well. So I wanted to also get more objective data by doing the BEST testing, the isokinetic testing, other things that we've learned about in class, just to make sure there's a well-rounded evidence that they are ready to return to play. And then the systemic reviews had some return to play protocols, but they are all vastly different. And then I also found some surgeons' protocols that were out there that are not validated, but they were very similar to all the ones listed in the systemic review. And basically what I found out was there's no standard timeline. Every athlete is different, and you just have to incorporate functional tests and measures to make sure you're advancing them when they're ready and not before they're ready. So a functional test with quantifiable measures would allow an athlete who recovers quickly to return when they're ready, and then delaying anyone that's not ready from returning too early. So I feel like we did all the right things, and hopefully she's good to go from there. And this is my bibliography.